you, Michael, for the introduction. I'll just set this up as slideshow. And hopefully, as I'm about to start talking about digital health and technology, everybody can hear and see this okay. So I have a particular research interest in remote patient monitoring and digital health for patients, in particular within a specialist palliative care service. So I'm delighted to be speaking this afternoon on new solutions for old problems, the promise of digital health. And I suppose on reflection of the morning sessions, there were some fascinating talks there. There will be a little bit of overlap at certain portions of my talk, and I hope that this is a really good sign that we actually are on track in terms of evolution and shifting away from withering. So just to start off, I suppose we first of all need to consider what digital health is. So for full disclosure, I am not a Trekkie. I apologize to any avid Star Trek fans that may be in the audience if any of my information is incorrect. But the gentleman on the right-hand side of our screen is EMH Mark 1, or Emergency Medical Hologram Mark 1, or the doctor, particularly of Star Trek Voyager fame. And this little nifty device on the left-hand side of the screen is the doctor's tricorder. So a tricorder is a digital healthcare device that is capable of scanning a patient's body, so remotely and without direct contact with the patient. And this is giving Mark a wealth of information in terms of bodily function, organ dysfunction, vital signs, blood results, etc., without any invasive techniques used. So I suppose this is what digital health looks like aboard the USS Voyager in the 24th century. But for the next 30 minutes or so, we're going to consider the landscape in 2022, maybe think about some of the evidence base for digital health within palliative care, and then think about what the future may actually hold for us in terms of service provision. So essentially, digital health is this intersection between healthcare and technology. It's worth noting that there are over 27 various published definitions of digital health, but essentially it is this broad term that's used to refer to the application of information and communication technologies and networks for the management, delivery, and optimization of patient care and health services, and for supporting patients themselves. So it encompasses a range of related concepts, some of which will be quite familiar to us, such as telemedicine, telehealth, and electronic health records, and also mobile health, health informatics, and wearable devices, such as Fitbits and activity trackers. And stakeholders within the digital health field include patients, practitioners, researchers, app developers, medical device manufacturers, and distributors. So the adoption of digital health within the healthcare sector has been really dramatic in recent years. And if we just think about the global market for a moment, it's estimated that by 2024, the digital health market will be worth over 300 billion euro worldwide. I don't really want to linger on the C word, but in terms of the COVID-19 pandemic, we saw this dramatic upsurge in the use of telemedicine, and in particular within our own services as well. And funding for telemedicine has been increasing exponentially, so by more than 130% year on year in recent years. And funding for remote monitoring companies in 2020 actually doubled. So I suppose we have this field that is showing no signs of slowing down and is only going from strength to strength. And I think it's time for us within the healthcare service to start thinking about how we can harness some of the digital health uses in order to improve services and efficiency and patient care. So this is Henry Ford, and Henry Ford is the founder of Ford Motors. So he is credited with revolutionizing the automobile industry. So he came up with the concept of assembly line production of cars. And he made the excellent point that we don't make changes for the sake of making them, but we never fail to make a change once it's demonstrated that the new way is better than the old way. So in terms of digital health, is the new way potentially better than the status quo? If we just think for a moment about some of the pros and cons to introducing digital health interventions, I suppose first off, if the main output of a digital health intervention is in terms of its novelty, then that's going to be of absolutely no benefit to us long term. And there's no need for us to be using interventions with a novelty focus. And similarly, if we can't prove that either the clinical effectiveness or the cost effectiveness of potential interventions, then within a healthcare service, they're of no benefit to us long term, as this will not be sustainable. However, on the flip side, it may be considered that there are many reasons for potentially introducing interventions. So some of this may be born of necessity. And again, the pandemic showed us this, that the use of telemedicine dramatically helped with care for our patients in that period of time. We know that we're living in an era where the rest of our lives are becoming more digitalized and we're spending far more time online than ever before. And there's a significantly increased focus for patients on personalized and individualized medicine. In terms of unmet need, we know that services are, struggling to cope in certain terms with demands upon services, and that's true of specialist palliative care as well. So digital health has potentially promise in terms of meeting some of this need. And again, if we can improve either the clinical effectiveness or the cost effectiveness of some of these interventions, then it is possible that the new way is better than the old way. So if we think about maybe a particular need for transformation within a specialist palliative care service, we know again that worldwide demands on our services are increasing. And if we look at an Irish focus for a moment, this paper was looking at population-based palliative care planning in Ireland over a 30-year period, so bringing us up to the year 2046, and had some really important and interesting findings. So by 2046, it is expected that there will be an increase in projected deaths from all causes of 68%. And again, in 2046, the projections would show that the number of patients who are living with a palliative care need will have increased by 89%, and that the number of patients dying annually with a palliative care need will have increased by 74%. So this is really significant for us in terms of planning for the future. Similarly, just in reference to Dr. Creedon's talk this morning, and again, the importance of Sláinte care and showing us this need for transformation, one of Sláinte care's strategic action points has been devoted to developing a modern e-health infrastructure. So particularly in reference to electronic health records, which again, Dr. Creedon has discussed the absolute importance of telemedicine and of e-prescribing also. So the need for transformation is being recognised within the service. This is not just unique to Ireland. The European Commission has highlighted some of the current and future issues in terms of the workforce in particular. So as things stand, we have this aging workforce and significant issues with recruitment and retention of staff, and a significant distribution of services in certain geographical areas. Looking to the future, we have this aging population and as a result, changing care demands. And with this comes new treatments for certain things, but alongside that comes new and novel side effects. And again, how do we impact on these issues? So the European Commission itself has also highlighted digital health technologies as one potential route of mitigating some of the risk of these issues. So in terms of again, referencing Prof. Davis's talk on the importance of research and the evidence base, if we look to the evidence base for a couple of minutes, this systematic meta-review was published early in 2021 and was looking at digital health interventions in a palliative care population. So the first thing to note is that there was a wealth of publications within the systematic review, and they set out with the specific aims of identifying digital health interventions used in the context of palliative care, to describe the overall quality of the evidence, and to synthesize the evidence on the role and the effects of these interventions in palliative care. So at the outset, I think it's important to note that about 39 of these publications, so representative of about 12% of the overall number of publications, was of level 1 evidence. So level 1 evidence being our prospective randomized controlled trials, so high grade evidence, and over 200, so the majority of publications were of a level 3 evidence. So this would be more in terms of retrospective reviews. So I think that's just important to note at the outset. They specifically looked at the types of digital health interventions being used and their purposes. So the main types were in terms of video conferencing, electronic health records, phone and mobile phones, online and video. And the main purposes being reviewed, so that the research that's being done in this area is in terms of digital health interventions for education, for symptom management, for information provision, for decision-making support and communication. So in terms of their findings, they broke their findings down into these 7 different subsections. So we're just going to look at each of these in a little bit more detail. So in terms of using digital health interventions in palliative care for an educational role, the main interventions being used were in terms of online learning, video conferencing, and online symptom reporting for caregivers. So they acknowledged that most of these studies were mainly descriptive in nature, and the outcomes and I suppose the methods used were very heterogeneous. So it's very difficult to extrapolate any definitive evidence from this, but overall they felt that the evidence was mainly positive. So this means that digital health interventions may have a positive role in terms of education. In terms of symptom management, the main interventions were the use of electronic health records to record symptoms and video conferencing to monitor and treat symptoms. So they noted some positive impacts of these interventions, mainly in terms of the effect on psychological symptoms for patients, but overall the evidence is inconclusive for the role of DHIs in symptom management. In terms of information sharing, there was a positive impact overall of the internet, online support groups and chat rooms, and the electronic health records helped to improve sharing across settings, improved continuity of care and the clinical workflow. So this is exactly what we would be hoping to see. In terms of decision-making, there was some evidence for the efficacy of video in facilitating decisions relating to advanced care planning, some evidence for the improvement in completion of advanced healthcare directives, and as an aid in discussion of end-of-life preferences and improved knowledge for patients. There were again some positive effects on communication, so between patients, healthcare professionals and caregivers, and this was mainly with the use of phones, internet and computer services. The overall evidence for digital health interventions for improvements in quality of life was inconclusive. So the authors do acknowledge again that this is something that's frequently not being measured in research. And when it is, it's usually small studies with small numbers of patients. So overall, no statistically significant positive impacts. And finally, so their 7th subsection was looking at costs and resource use, and they found that there was a positive impact on costs of digital health interventions. And the cost savings were mostly associated with the use of video consultation and then travel expenses, so in terms of hospital attendances and home visits, etc. So I suppose overall, we saw that there was this huge number of papers included. So the research there is being done, but unfortunately, the evidence that's being produced is of very low quality. So we need to be careful that we're interpreting this with caution. It's worth noting that telemedicine was used far more than any other particular type of intervention. And the authors did acknowledge as well that none of the papers were looking at or reviewing the use of mobile health apps, etc. But overall, they've concluded that the evidence suggests that digital health interventions can be useful, safe, and acceptable to many terminally ill patients, their caregivers, and staff involved in their care. So some hopeful findings there. So then a quick search of the database. So that systematic review was published in about April of 2021. Since then, so in the space of less than a year, there have been 2 or 3 other systematic reviews specifically looking at digital health interventions in palliative care. I'm going to mention this one because this was looking at virtual models of palliative care, so within a community palliative care setting, and this was published in September just gone. This was a systematic meta-review. So similar to our last review, this is a systematic review of systematic reviews. So the outputs from this should give us quite high level evidence. And they set out to look at what digital health interventions are being used in a community palliative care setting. What was the impact of these interventions? And what are some of the barriers and facilitators to these interventions in the community? So again, their final analysis included over 150 studies. The vast majority of studies were looking at scheduled telehealth, video conferencing, and some were looking at after-hours telephone support. So their overall findings were that there was this huge proliferation of reviews, but unfortunately insufficient evidence to identify an optimal model of virtual palliative care in the community. So they found significant gaps, I suppose, in the evidence base, but felt that there was also significant potential to improve this, and concluded by saying that understanding how to harness and adapt emerging digital health technologies is critically important and should be the focus of future well-designed effectiveness trials. So far within a palliative care setting, we don't have any robust evidence to support the use of digital health interventions. And I suppose what we need to consider is, are there lessons that we can learn from elsewhere? So if we shift our focus to our colleagues in an oncology service, so a huge amount of effort has been put in oncology services to look at remote monitoring of patients using digital health interventions. And there's a vast amount of research published out there on this. And overall, they've had quite positive findings. So in terms of remote monitoring, they've found that there is improved symptom control for patients. There's improved quality of life for patients. There's improved survival for patients. And there is reduced use on hospital services. So in terms of outpatient attendances, emergency department attendances, and inpatient admissions. So I've just referenced 2 of these studies, and we're actually just going to look at the second one in a little bit more detail. So this was the ESmart project, and this was published again just in 2021, so quite recently. And essentially what this ESmart group set out to do was to look at the evidence for use of a mobile health digital technology to support patients whilst receiving chemotherapy. So it was Europe-wide, it was multi-center, and it was a randomized control trial. It included over 12 cancer centers across Europe, and 829 patients were randomized to either intervention or standard care. So specifically, the intervention group were followed in real time. They had 24-hour monitoring, and specifically they had management of potential chemotherapy toxicities. The ESmart group were also looking to identify earlier episodes of neutropenic sepsis. So patients were followed over 6 cycles of chemotherapy. And in terms of demand on patients, so they completed a validated self-reported questionnaire on a daily basis. So this was a daily chemotherapy toxicity self-assessment questionnaire. So questions specifically relating to toxicities. At the time of completing this questionnaire, they took their temperature using a digital thermometer, and this data was uploaded to their mobile device. If a patient reported symptoms, they were able to then access self-care advice via this management intervention on the mobile phone in terms of symptom management. And what was really, I suppose, unique about this study was that they had an alert system for clinicians. So essentially, a clinician would be on call within any of these 12 cancer centers to respond to alerts. So if a patient developed specific symptoms that would set off an amber alert, the clinician was expected to respond to this within an 8-hour time period. If a patient developed a high temperature and this triggered an alert, or significantly worsening symptoms, the clinician was expected to respond within 30 minutes. So what did they find? So their primary outcome was the Memorial Symptom Assessment Scale score over the 6 cycles of chemotherapy. And their secondary outcomes, so they looked at functional assessment for patients, anxiety levels, and the supportive care needs. And each of these were measured using a validated tool as well. So very briefly, what they found was statistically significant differences or trending towards statistically significant differences for the intervention group. So patients who had access to this real-time remote monitoring system with potential to interact with clinicians should issues arise, scored better in terms of their functional assessment, their anxiety, their supportive care needs, and their physical symptoms as well. This paper references that there was a high adherence to intervention both within the patient group and the clinician group. However, this is going to be the focus of a subsequent publication that is not available yet. So that will delve into, the demands on the service at that stage. But the ESmart group concluded with the results of ESmart support the use of remote symptom monitoring in routine care for patients treated with curative intent. Now, I know that this is a different population that we would quite commonly see. But again, it's important to think about whether we can extrapolate from some of these results and use them for our own cohort of patients. So I would put the argument to you that we potentially can. So this study has shown that remote monitoring can be helpful and that it can work and that there can be good adherence. And within a community palliative care setting, where we have a service that can respond to patients' needs on a face-to-face basis or within their own homes, then we have the potential to actually augment our service by using something like this. So I suppose we've thought about the evidence base. And now if we spend the latter part of my talk just thinking about where the future might bring us to and how far away are we from having tricorders, your mind might be thinking there's so many different ways that digital health could go. And I would agree, but I'm going to be a little bit self-indulgent and think about some of my own mainly future work for the latter part of this talk. So first of all, we need to consider this paper. Now, Prof. Davis actually referenced this paper as well. So just as a very brief review, this systematic review was showing that community palliative care actually, has some questionable clinical outcomes for our patients. So specifically, this group were looking at the impact of community palliative care services on facilitating death at home for patients. They were looking at the clinical effectiveness of services, and they were comparing resource use and costs of services. So their final data had 23 studies included, which was representative of over 37,000 patients, over 4,000 family caregivers, and interestingly, they identified 19 different models of community palliative care. And ultimately, what they found is that there is good evidence to support community palliative care's role in attaining a home death. There's some evidence to support our role in symptom control. There is no evidence to support our role in quality of life, pain control, physical functioning, hospital attendances, family carer burden, or family carer grief. And there was inconclusive evidence on the cost effectiveness of community palliative care. So again, unfortunately, we're in a place where we don't have a huge amount of evidence to support what we actually do. And again, I would come back to, do we have the potential to use digital health interventions or technology to address some of these issues? So I'd like you all for a moment to consider this bespoke digital health intervention that has this remote, comprehensive, holistic assessment at its center. So this comprehensive holistic assessment is going to look at all patient outputs. So in terms of physical symptoms, the psychological symptoms, and the spiritual needs. So a lot of subjective data can be gathered through remote means. So in terms of patient reported outcome measures. So using a tool like Peacock, except, in a digital landscape. What is particularly novel is, in addition to all of these subjective measures, we can now add objective measures. So we now have the capability in terms of technology to be doing things like measuring a patient's vital signs remotely at home without the need for blood pressure cuffs or pulse oximeters, etc. And this is what I'm going to be focusing on with the majority of my research. So this schematic is courtesy of Prof. Davis's excellent PowerPoint skills. So this is what I'll refer to it as ORCHA for the rest of this presentation. This is what our ORCHA looks like in real time, in real life. So we have a patient and we have their caregiver who have access to a smart device, so either a smartphone or an iPad or something similar. And this iPad is going to be pre-populated with subjective assessment scores for a patient or their caregiver to complete. And again, uniquely, we are going to be able to upload objective assessments, so a patient's vital signs. So once this information is in a smart device, some of it, in particular in terms of our objective measures, which I will come to in a moment, will be uploaded to a cloud for analysis and processing. All of our results from these assessments can then be stored on a secure database where this can be accessed by a clinician. So now we have this potentially wealth of information in terms of subjective and objective assessments. And again, similar to thinking about a structure like the ESmart project, a clinician can then respond in real time should certain alerts be triggered. So what does ORCHA give us? It gives us all of this excellent real-time data for our patients in the community. It gives us longitudinal data, so data over time that we can track. And in turn, with an alert system, this gives us the opportunity to respond in a timely manner and to target interventions depending on the needs of our patients. So in turn, we would hope that this would lead to a more efficient use of services. Just because I think this is maybe sometimes a little bit of a contentious issue within specialist palliative care, there are very opposing sides on whether we should be monitoring vital signs, in particular as patients approach end of life. So there are arguments for both, but I suppose some of the considerations are, is this practical in a community setting? So if we don't have, if we're not face-to-face with a patient, how is this going to be managed? But we know that vital signs can give us significant, important information and help us to identify early points of deterioration for our patients and potentially reversible illnesses. And there is a little bit of evidence out there to show that specific trends in vital signs can be of some use for prognostication for our patients, which is of importance as well. So how do we remotely measure? And I would also add here in a non-contact way, measure vital signs. So I'd like to introduce you to the concept of remote photoplethysmography. So a mouthful to say, but potentially game-changing in terms of what we can do within a digital landscape. So plethysmography essentially is the measure of change in volume in the body. So if you think of a blood pressure cuff, this is working off the concept of plethysmography. Photoplethysmography is a development on from this that uses a light source and a sensor to measure changes in the blood volume just below the surface of the skin. So photoplethysmography is the concept behind a pulse oximeter. So if you've ever seen the red light on a SATS monitor, that is the light source. So we're now working with this highly innovative company that have taken this technology, manipulated it, and made it remote and non-contact. So how does this work? So if you think of your standard smartphone, or again, iPad or smart device, all of these now have a camera built in. And each camera within these smart devices has a little sensor. So I've mentioned that we need a sensor and we need a light source. So we now have our sensor. In terms of our light source, again, this company has developed the use of ambient light, so the light around us in the environment as its light source. So this is a schematic of how it works. So essentially by holding a camera, a smartphone camera up to a patient or using it in selfie mode, the light is reflected off the surface of the skin or off the blood vessels just below the surface of the skin. These signals that are picked up are turned into this color scheme that is uploaded to cloud-based services. So this is important in terms of analysis. These signals pass through independent component analysis, or ICA, which is a form of artificial intelligence. And in turn, the signals are processed and either returned to the smart device or uploaded to a secure database for viewing by a clinician. So essentially, we now have this technology that just by looking at the camera of a smartphone, we can within 40 seconds have our heart rate, respiratory rate, blood pressure, and oxygen saturations returned to the screen. So again, potentially game-changing. So just in terms of, again, using these assessments and how it would impact on our patients. So just in the interests of time, we might just look at the red line at the bottom. So in terms of if a patient is developing symptoms that are uncontrolled or their vital signs are becoming quite unstable, we would then have the ability to send an alert to their clinical team, prompting immediate review and urgent intervention, either of that symptom or potential deterioration. Similarly, if a patient's symptoms are well controlled and their vital signs are stable, we can ensure that they are in a cohort of patients that are for routine follow-up, but we would also be safe in the knowledge that if symptoms or vital sign changes were to arise, that this can be responded to in a timely manner. So just before I finish up, I think it would be remiss of me not to just mention some of the considerations that need to be taken into account within the digital health intervention landscape. So the digital divide is really, really important. So this is essentially the gap between people who have access to and know how to use things like the internet and services and gadgets that are out there. And there are many reasons for this gap. But if digital health is going to become a part of our future within healthcare, we need to start thinking about how big that gap is and how do we start to close it. In terms of infrastructure, again, this would involve patients having robust access to internet services, etc. And interestingly, there is no place within the legislation in Ireland that references digital health. So, again, this is an important area. There is legislation being drawn up within the European circles at the moment, but this is going to be vitally important to ensure that technologies are being used safely and correctly within our services. And really importantly, I think we need to say that in terms of digital health interventions, we need to be sure that we are using these to augment our service, so to improve our service, as opposed to replacing what we're really good at, as opposed to replacing that face-to-face contact, and that is vitally important for patients. And again, we always need to consider the cost effectiveness of what we do. So I'm very much hoping that this isn't the last you hear of ORCHA or remote photoplethysmography, or indeed myself. All of this work is in its very early stages. So I'm in the very early stages of my PhD. However, I would hope that in the not so distant future, I'm going to have lots of rich data to present to you all in terms of this work. So I'd like to thank you all for your attention, and I'd be happy to try and answer any questions that you may have.